Hello, my name is Laura Maria Calderone, host and producer of The Long Haul, an online series on long COVID. With us today, we have from Research Aid Networks, my co-host, Dr. Jeremy Rossman, a virologist of the University of Kent. Hi, Jeremy.
Hello, nice to see you today.
Nice to see you again. So we spoke a couple of months ago in one of the very first episodes of The Long Haul. And now it's mid-July 2021, second year of the pandemic. And we are doing another episode together, and it's more of the long haul answers questions that we received on everything to do with long COVID. As we spoke about before, we decided to do this episode now because there has been some changes on long COVID. We have more and more countries that are talking more about long COVID. We have even countries such as Canada and Italy that have officially recognized long COVID. And of course, there are new variants of concern, such as the Delta variant spreading around the world. And the other biggest thing is it's been half a year or so that the biggest vaccination rollout in history began. So now we want to know, what does this all mean with long COVID? So welcome to a special episode of The Long Haul, where we answer some of the most important questions on long COVID. So let's kick it off. And Jeremy, let's go back to the basics. Let's start this episode with, what is long COVID?
We really need to make sure that we're all working on the same page, that, all of these concepts and terms that we're hearing, that we're able to really understand and explain them carefully so that we know that we are all talking about the same thing. And too often that's not being done right now. So you're hearing about long COVID, but you're hearing about a lot of different terminology. And what exactly is it? So the simple answer is that if you get infected with the SARS-CoV-2 virus, you get COVID-19 disease. This is the acute disease. For some people, it's completely asymptomatic. Some people have very mild disease, and some people have incredibly severe disease that can require hospitalization. Now, in some people, those symptoms that you have completely recover. You recover from that initial acute disease and you return back to your health that you had beforehand. But in some people, you're seeing this either continuation of symptoms, that what you get in that acute phase never goes away, or you're seeing a little bit of resolution and then you're seeing symptoms return. And these symptoms are not necessarily the exact same things that happen during the acute infection. They can be different, they can change over time, and you're seeing this really variable response where you get a lot of different symptoms that change over time. But the main principle here is that you're getting continued symptoms. You're not seeing that full recovery from the acute viral infection, even though you're no longer testing positive for COVID-19. So this is after that acute infection, you don't fully recover and you have continued symptoms for an extended period of time.
So one of the things that you just mentioned is that you can even test negative, but it shows you have the symptoms. That is the continuation of it. Another thing that we keep on seeing, and it's actually one of the questions that I'm asked all the time, and it is, okay, but since you're doing this whole, you're into long COVID and you're doing these things, tell me, does it matter what type of COVID you had? If I get, a symptomatic, so quite or really mild, then it means I won't get long COVID, right? Because only severe. And I'm like, unfortunately, that is not the case. Can you tell us a little bit more about that? Why is it that you have people that have had no symptoms or have had very mild symptoms, have had a mild course, and they have long COVID?
It's a really important point because there is that perception that if you're having any sort of long-term severe disease, well, that must have come from a severe initial disease. But that's absolutely not the case with long COVID. You can have incredibly mild initial disease and develop long-term symptoms. And there's also that perception that long COVID is just the sort of continuation of the symptoms from the initial infection. And sometimes that can be true. But often it's that you have that initial infection and then the long COVID symptoms are actually worse, that you get more symptoms and that you get worse symptoms over time instead of recovering. So it's not just versus severity, it's any case of COVID infection can lead to long COVID. Now, you did mention one aspect of severity, and I think something that's really important to talk about and to differentiate is that people that do have severe cases of acute COVID causes a lot of damage to the body, and that can take a long time to recover. But this sort of long-term recovery from an acute infection is not the same thing as this sort of active disease process that we're seeing, where you're getting that long-term symptoms, where people are having symptoms for 3 months, for 6 months, for a year. That is a very different process just from having a severe infection and your body taking time to recover.
You mentioned, obviously, because that is one of the most important things when we talk about long COVID is symptoms. I doing these series of the long haul and having spoken to different people with different lived experiences as a long hauler, we speak of different symptoms. Some of them, there is a tie between all of them. There is some repetitive ones, but can you just tell me what are the symptoms of long COVID and why is it that there's so many symptoms and they're so different from each other?
So to actually go through and talk about all the different symptoms that are associated with long COVID, we would need a complete episode just to go through the symptoms because there are so many. So just to give you an example, there's a recent study that was just done by Body Politic that was looking at, what symptoms patients are experiencing in long COVID. And, they were seeing over 200 different symptoms that were affecting 10 different organ systems in the body. So, I mean, this can affect almost everything in the body, huge range of symptoms. And there's that variability in symptoms from patient to patient. There's that variability in symptoms over time. And there's that variability in intensity of symptoms. But, when you go look at that list, some things really popped out as being the most common symptoms that patients are reporting. And there were three most common symptoms, and that was fatigue, post-exertional malaise, which is basically fatigue that happens after sort of any sort of exertion. I mean, that doesn't necessarily mean exercise. That can be sort of walking up a case of stairs. And brain fog. So those three symptoms are the most common ones seen with long COVID patients. Now, there are a lot of others, and it's typical that most long COVID patients don't just have one or don't just have these three. Again, they will affect a lot of different body systems, respiratory issues, circulatory issues, skin issues, a huge range. But I think one thing that's also really important to mention here is that, if you look at those three symptoms, they're not symptoms that you can just look at a patient and see that how sick they are, see how they feel. These can often be, hidden symptoms, very clear to the patient, but you can't just look at somebody and say, oh, that patient is really sick, that patient has long COVID. And so I think that's something really important that we need to be paying attention to when we're looking at long COVID as a disease, is that it's not something that is always going to be really visible just looking at a person.
And it's interesting that you mentioned that because going back to this lived experiences, because that's how we get to tell the stories, right, of these long COVID patients and their loved ones. And one of the last guests that we had at the long haul was a young 31-year-old woman, and she actually, before the pandemic and everything, was very healthy, no underlying condition. And if you, I mean, we had to postpone the interview a couple of times because she just couldn't do it, you know? And the time that we did do the interview, when you look at her, she looks okay. She looks fine. But then you do, as time goes on, you see a little bit that she's tired. And then when we finished the interview, we spoke and it took a lot out of her. But the interesting and sad thing, obviously, is that, like you said, it's many symptoms and they don't just come, there's no schedule to it, right? They can have, there can be many at the same time, or they can change, you know, different days, different things. And she was an independent young woman, lived by herself and everything. And because of her having long COVID, her family had to move back to the country and live with her in order to help her. And she, I mean, that's one tip, that if you have long COVID and if you're able to, because not everybody can, or you, if you have the support, write down your symptoms, write down, journal your journey. And that's what she did. And it's really impactful because she, throughout, it's since March 2020 that she has long COVID, and she's had around 52 symptoms since then. And now when I spoke to her, she told me she was better, she was feeling better, because she only had around 30. So it's a lot of symptoms and they're very different. Can you tell us a little bit more about the symptoms? Does it depend how old you are or what type of life you had before, if you're female or male? Or
We know a little bit about sort of risk factors, or groups that tend to get a little bit higher or lower incidence of long COVID. But in terms of understanding exactly why some people experience, say, brain fog as one of the primary symptoms that they have, and why some people might be experiencing circulatory issues as one of the primary issues, we really don't understand that yet. We don't really understand, why different symptoms cluster together, why certain people have some symptoms, and why they change over time. I mean, we do know a little bit that in term that women have a higher rate of long COVID than men do. That when you look at data from the UK, from the Office of National Statistics, we know that adults between 25 and 34 have the highest rate of long COVID at 12 weeks post-infection. We're at 18.2%. So we do know some things that show that there's a higher risk of long COVID. But in terms of what that means for symptoms, that's not really clear. And also, when you're talking about, say, the percentage of people that get infected that go on to develop long COVID, well, yeah, there's a higher rate in that sort of 25 to 34-year-old age group. But any age group can develop this. I mean, even children, there's data that says children between 2 and 11 have a rate of developing long COVID at 12 weeks post-infection at 7.4%. So even children are getting long COVID. It's not just adults, but we do know that sort of really typically healthy middle-aged adults are really getting that highest rate of long COVID illness.
so you actually opened the doors to another question that we were going to speak about. We received also questions on this, but it's one of the questions that makes the most sense when you talk about long COVID, right? And it is, okay, just give it to me straight. What is the probability of me getting long COVID after I get COVID, right? And one of, which makes sense, right? Just tell me, how worried should I be? One of the things, one of the questions that we received was, okay, why do different studies say different things? Because specifically, this person said, okay, I just want to know if there's a scientific data on how high the rate of infected people is that catch long COVID. Because the studies I have seen, they differ from 2 to 10%. Is it more? Is it less? And kids, what about the children?
It's an incredibly frustrating thing. And if you're going and you're reading, articles and newspaper stories that have come out talking about long COVID, you're seeing this huge range in how likely it is that somebody that gets infected with COVID will go on to develop long COVID. I mean, you're hearing rates as low as 1%, you're hearing rates as high as 60 or even 80%. And you're even seeing a lot of variability in that percentage in scientific studies. So, how do we know what numbers to trust? How do we know what's real? And why is that? Why is there so much variability there? And I think, in terms of that variability, it's all about how we're getting that data, how we're defining what long COVID is, how we're defining whether or not somebody was infected. So if we sort of walk through the whole process, we can see, a lot of different points where you're getting this variability coming from. So first of all, if you're going to say, okay, how many people have long COVID in a group? Well, first of all, you have to define what group you're looking at. So is this just a group of patients that were hospitalized? Often, a lot of studies are only looking at hospitalized patients and saying, of people that were at the hospital over this period of time, how many of them were diagnosed with COVID, how many were not, and then how many went on to develop long COVID. And that's great because they have a lot of data for that, and it's a little bit easier to be able to do that analysis. But then you're only looking at patients that went to the hospital for some reason. And so that's giving you only a small subset of society. Now, you could also look at it, a different way of how are you testing and saying, how are you defining that somebody was infected with COVID? So is that from, active testing? You have this cohort of people and you're testing everybody with, say, PCR every day and saying who was positive, who was negative, and then who went on to develop long COVID. That's great, but often that's not done. So what's done frequently is looking retrospectively and saying, okay, did any of these patients have a positive PCR test? Did any of these patients have a positive antigen test? Or did any of these patients have a serology, an antibody test that says whether or not they were previously infected? That can give you some data. But again, each of those sets of ways of diagnosing COVID can lead to different outcomes. Different percentages of patients will report one versus the other. And then often you have a lot of countries where, COVID, especially earlier on in the pandemic, is not something that was being actively tested for. And so you have a lot of patients that weren't able to get tested, even if they had severe symptoms. And so a lot of surveys that are looking at long COVID also are looking at sort of patient reported information. So do you have data that says, you had symptoms that suggested that you did have that acute COVID infection? And so we're going on that patient reported data. And I think each one of those ways of assessing COVID infection leads to different numbers. And it's really important, though, because you can't rely on just one, because only some people got PCR tested. And if you go look for antibodies, well, not everybody that got infected develops an antibody response. And how soon were you doing that serological test? So all of those have pros and cons. And really looking at all of those different measures is really important to get a real good perspective as to the percentage of people developing long COVID in the population. So that's hugely variable. But then how do you define long COVID? That's another aspect that's hugely variable, because some studies are using very narrow definitions. Some are using very wide definitions, how many symptoms you have, what symptoms you have. And then how long? Because some studies are only looking at a couple weeks post-infection. But a couple weeks post-infection, that might just be part of the body healing. But if you go further out, some of the sort of more robust studies are looking at 12 weeks post-infection, looking at 6 months post-infection, and there you're clearly seeing a different process. It's not just recovery. This is an active disease process. And so how you factor in all of these variables together gets incredibly complicated and leads to so many different numbers. And that's not even touching, does this have an effect of what variant you were infected in? Does this have an effect on, what sort of precautions were being taken in different countries? What was happening in different countries? There's so much that we don't know right now. But some of the best data is coming from the UK and the Office of National Statistics that is doing really big surveys looking at the incidence of long COVID. And for their data at 12 weeks post-infection, what we can say is that our best guess as the risk of developing long COVID overall is about 14% of people will still have symptoms 12 weeks post-infection. But as I said, that varies, 25 to 34-year-olds, that's up to 18%. Children 2 to 11, that's down to 7.4%. But everybody is at risk.
And if we take this data, because you said 12 weeks post-infection, right? Taking that into account, it's important to remember that we don't know how much longer after those 12 weeks, because it could be, even 1 week after, but it can be 1 month. And unfortunately, we have seen it can be 1 year after, and we still don't know for how long, because we're in the present, right? Not in the future. So we don't really know how long it will take. So this question is very difficult because it has, like you mentioned, many variables. Would it be correct if I define it in the simplistic way of explaining is that the difference between one study and the other is mainly due to what they're studying, when they studied it? That's where it is, right? Did they study this back in March where it was still too soon to see? Did they studied it now? Did they studied it in the UK or in New Zealand, where, as we well know, they thankfully haven't had a really bad pandemic reality, right? So
what did they study? When did they study it? Where did they study it? And how did they study it? How did they define what they're studying? All of that comes together to affect the numbers that they get, which is why you get so much variability here.
So the point is, not everybody that has COVID, it ends there. Some people get long COVID.
Yeah.
You spoke at the beginning about terminology, right? So which affects the definition of long COVID also, right? So how are you defining what long COVID is, the timing, the symptoms, and so on? But we had a question that basically said, okay, every country and author uses a different terminology when speaking about long COVID. You hear PASC, post-acute sequela of COVID-19. You hear long haulers, you hear long COVID, persistent symptoms, sequela, so on. What is it that makes the terminology official? Why are there so many different names? And is the World Health Organization responsible for naming it?
This is, this is something that makes this very difficult. And, when we talk about those studies and the variability, part of that is, well, how are you defining this? And part of that is also terminology, because terminology affects how we're talking about it. But terminology also plays into, is there a diagnostic code when you go to the doctor or when you go to the hospital? Is there a diagnostic code that your country is using that your physician can say, yes, this is long COVID, and we're going to diagnose you with that, and then we know that you have long COVID? Or is it a collection of, here are all the codes for all the different symptoms, which is how it's been for a very long time and how it still is in many different countries. So the naming, there's no real uniform, naming mechanism here. The closest thing to any sort of mechanism for naming does come from the World Health Organization, as you mentioned, and it comes from this idea of diagnostic codes. This idea of, if you're going into a doctor, do they have a code that they can pull down on their computer that says this is long COVID? And so the World Health Organization did define a diagnostic code of post COVID-19 condition unspecified. That's what the official terminology is. But that's also fairly vague right now. And so other countries can then adopt that code and use it. But often a lot of different countries are using other terms. So, patients using long COVID. This is a patient-defined term, long COVID and long haulers. But in the US, for instance, we're hearing a lot about PASC, as you mentioned, this post-acute sequelae of COVID-19. And in governmental organizations like the CDC and the NIH, often this is really becoming the sort of most commonly used terms. But it's sort of, there's just a convention and sort of an uptake of different terms. And this has already changed over time and is probably going to continue to change over time. And even that diagnostic code from the WHO, this might change over time. So unfortunately, right now we're in a scenario where you have a lot of different terms. Different organizations are using different terms. Different countries are using different terms. Some countries are using the diagnostic code, some countries aren't. So there's, again, unfortunately, a huge amount of variability. Now, I think over time, this is going to settle a little bit, and it's going to be that there's a convention of, these are the terms that are used most commonly, but it could end up being something that you see like, this is post-acute sequelae of COVID-19, and then in parentheses, long COVID. It's hard to say, but I think that this is, we are not at the end point of naming right now. And I hope that it gets clearer over time. And I expect that it will. But right now, there's just a lot of different terms and a lot of variability.
And still a lot to do because, like you said, it's not only about the term, but it's even the definition itself, right? How
Yes.
do you define long COVID? And this definition is in countries that have acknowledged long COVID, because unfortunately we have still many countries around the world that do not speak about long COVID and have not acknowledged long COVID as a reality of the pandemic, right?
Yeah, it's a big problem.
So yeah. Um, the last question I have on this part of our episode on the basics of long COVID is a question that, I mean, I can understand why it's been asked, and I wanted to hear from you. What do you say to it? So the question is basically, why are we talking about so much about long COVID? Why is it long COVID, long COVID, long COVID? There has been long-term effects from viruses before this pandemic, and they haven't been talked about as much as long COVID. So why is it that a long-term effect from a virus as the Ebola virus was not really spoken about, and now everybody's talking or wants to talk or at some point talks about long COVID?
It's a matter of the scale, it's a matter of the time. So you're absolutely right, though. Having long-term symptoms coming from a viral infection is not new. We've known this occurs. We've been seeing, after the 2016 Ebola virus outbreak in West Africa, we've seen a lot of Ebola virus survivors that have long-term symptoms. And there have been studies on this and people have been looking at it, but it has nowhere near the attention, the awareness that is coming from long COVID. But well, right now we have almost 190 million cases of COVID-19. And if we're looking at about 14% of COVID infections go on to develop long COVID, well, then you're looking at about 26 million cases of long COVID around the world already, just since the start of the pandemic. And then, that's not even factoring in the fact that, we're still getting very robust virus transmission in many areas of the world. And, each of those infections, has perhaps a 14% chance of leading to long COVID. So this is a tremendous number of people that have long COVID and a tremendous number of people that are at risk of developing long COVID. And so I think that scale and that urgency is a really big part of why we're hearing so much about it right now, why we're talking so much about it, because this is an acute health crisis. But this is also an acute health crisis that has long-term implications.
Yeah, it's the numbers and it's also the timing, right? This started in 2020, where it's all about social media, it's all about sharing and talking and knowing and saving. And we didn't have that in other epidemics, other pandemics. So we weren't so aware all the time of everything that is going on. So it feels like more also, right?
Yeah, exactly. The way information is being shared right now is incredible. And sometimes this can be really good. This social media and information sharing has allowed the formation of so many of these long COVID patient support groups that have really helped to not only get that patient support, but catalyze advocacy and awareness in countries where long COVID isn't being recognized, isn't being talked about. It's allowed for a lot of these patient surveys that have really helped to inform what actually is going on with long COVID disease. So it's been hugely beneficial, but also misinformation spreads just as easily. And it's often very hard to know what is true, what is not in information that's being spread on social media. So it is definitely a new way of understanding and learning about a disease with some real strengths, but also some real difficulties.
Exactly. That's, I mean, two sides of a coin, right? In anything. And that's what we have. So now we move to the other part of our episode, which is variants. So as we spoke before, the situation right now around the world is that there's more interest and more concern on the latest variant of concern, the Delta variant, because of its transmissibility, right? That it's the data so far has shown that it's more transmissible than smallpox. And we have cases that are sky high in many places around the world, from the Netherlands here next door, to the UK, to Spain, but then to Tunisia, Indonesia. And even in places where the numbers, the incidence is quite low, such as in Germany, where I am at, still the cases that we do have, even if they're not many, it's around 65% of them that are the Delta variant. So what I'd like to know is, before we speak about variants and long COVID, because that's what we're going to talk about now, what does it mean for long COVID? Tell us a little bit more about this specific variant, the Delta variant. How does it compare with the Alpha variant that was identified last September and that it went, spread around Europe and the world?
So to start with, as we're sort of so focused on, making sure that we're very clear with terminology and what it means, is, just to say, what is a variant? And a variant is basically just every time the virus infects somebody, it changes just a little bit. It makes some little mistakes, and so it comes out a little bit different. Now, most of those changes don't really do anything to the virus. The virus behaves the same. But sometimes those little changes can affect the virus. Maybe the virus spreads a little bit faster, or maybe the virus causes slightly different disease. Those are the variants of concern. Now, we've had variants from the very beginning. This is nothing new. The second we had the SARS-CoV-2 virus, we started to get variants. But over time, we've gotten more and more of these variants of concern as we've seen variants that do spread faster or do start to evade the immune system. And so you mentioned the alpha variant, and this was one of the first ones that we had a lot of attention to because it did transmit faster. And so now we have Delta, and we actually have a lot more. We're hearing about Lambda, we're hearing about Kappa. There's a lot of different variants, and they're going to continue to be new variants as long as the virus continues to spread through the world. But Delta itself, and the reason why we're concerned about Delta, is that Delta is 60% more transmissible than Alpha. And Alpha was already a lot more transmissible than the original strain. So the virus is continuing to get more transmissible. And what that means is that it spreads easier from person to person. And so that has a couple implications. So, I mean, first of all, that means that, if you're, say, in an indoor space and, the ventilation isn't great, or there's not enough distance, or not everybody's wearing masks, the risks of the virus spreading from person to person is getting higher and higher. But it also means that, groups that maybe weren't at quite of a risk of getting the virus, we've known that children don't get infected as easily as adults do. But the more transmissible the virus gets, the more that children are at a risk because the virus is getting more infective. And so they're still at a lower risk than adults, but that baseline of the risk is increasing. And so this transmission really affects so many different aspects of, what the variant is doing in society. But the Delta variant also has another important implication, which is immune evasion. Because we know that the Delta variant is able to resist some of the protection from vaccines and some of the protection from previous infections. So it's not a complete evasion of the immune system, but it does mean that it's starting to evade. And we've started to see this before with some previous variants, and we're going to continue to see this, but we are getting a little bit of that immune evasion.
When you say some, do you mean some depending on which vaccine you're getting, or if you're talking about the Delta variant?
But what we can say is that, yes, if you're looking at, say, vaccines, which vaccine you got plays a role. Did you get one dose of the vaccine? Did you get 2 doses of the vaccine? How is that working? So, for instance, if you're looking at the Pfizer vaccine, we've seen that there's a reduction in efficacy of how well that vaccine is able to protect people from getting any sort of symptomatic COVID disease. Now, it's still very good at protecting, but the data is that it's reduced between 65 and 79% from a much higher level of protection that we were seeing before. So it's a reduction, but still, 65 to 79% protection from any symptomatic COVID disease is still really good. And it's really important to note that even though we're seeing that reduction in people getting symptomatic COVID disease, what we still see is that vaccines like Pfizer, and actually all of the vaccines that we're really talking about, giving very solid protection, AstraZeneca, Moderna, Pfizer, Johnson & Johnson, all of these vaccines are still extraordinarily good at preventing people from getting severe COVID disease, from getting hospitalizations, from COVID fatalities. So Pfizer is still at 93% efficacy of protection against the Delta variant for severe disease. So we need to sort of distinguish that, are you at a little bit of an increased risk of getting COVID disease at all? Or are you at a risk of severe COVID disease? And if you're fully vaccinated, and this is 2 weeks post getting that second dose, then you're still at 93% protection of severe and fatal COVID disease. So the vaccines are still working well, but we are seeing a little bit of that evasion.
Just tell me this. From what you said, is it correct if I just basically hear what you're saying and I understand that it's a numbers game with the variants?
Mhm.
The more the virus is going around, the more it's going to change, the more variants of concern you're going to have. And in this case, a variant of concern, the terminology is quite apt, right? Because there are many variants, but there's some that are more worrisome than others.
Right.
And that's why they're called variants of concern. So the more virus you have around, the more you can have a bad variant.
Mhm.
And so the more it can become more transmissible. And so you mentioned about the kids, right? You mentioned that children, yes, it has been shown that they don't get infected as easily,
Mhm.
but we're talking about a certain reality. But if you have more virus circulating around the community, then
Yeah.
that little, let's say, even if it's 1%, 10%, whatever number you put there, there's a difference if we're talking about 1% of 10 kids and if we're talking about 1% of a million kids.
Right.
So it's a numbers thing.
It is, and this is why it's so important to remember is that even sort of saying that there's a lower risk does not mean that there's no risk or that that is a risk that is necessary to take, because we talk about a lot of countries sort of easing restrictions right now, and countries not even having sort of precautions in schools. And yes, having in school learning is really important for kids, but also making sure that the kids are safe is really important, because this risk for kids is increasing with the different variants, and we have precautions that we can take. And so it's just like you said, it is a numbers game, and we don't have to accept those numbers.
What I want to know is, does a different variant mean something different when we speak about long COVID? Like now with this Delta variant, is it is there more probability of me getting long COVID just because it's the Delta variant? Or how does it work? Does it change? What does change? What doesn't change?
I would love to be able to give you that answer. I think it's a really interesting question that we don't have any data on right now. So we don't know, if you look at, say, the original strain versus alpha or beta or delta, or even looking forward into any of the new variants that are emerging, if there's if those viruses are behaving differently, if there's a greater or lesser chance of getting long COVID. Now, part of the problem why we don't have that data and why that data is really difficult to get is that you're looking at transmission at very different points in time. What's going on in the world when the original strain was circulating versus, say, the second wave versus what we're seeing now. It's very difficult, very different in terms of precautions different countries are taking, and policies and testing, and medical awareness. And so that's one side that is affecting the risk of getting infected. But at the same time, there's this huge variability saying, well, if the virus is more infective, then your risks of getting infected are, of course, very different. So teasing that out from saying who is then developing long COVID, what's the rate of long COVID? Well, in theory, you should be able to do this, but it's difficult to do that analysis because you have to tease out a lot of different factors first. But you should be able to do it because you are looking for saying, how many people are developing symptoms that persist at 12 weeks. So even if the transmissibility is different, even if the country's taking different precautions, you should be able to tease that information out. Now, you have to wait a while, and that's part of the problem too, is that, if you're talking about at least 12 weeks post-infection, well, that data is getting very difficult to get if you're looking at Delta variants. And we don't have that analysis, even though in theory we could, for Alpha versus the original strain. So, it's really hard to say, separating transmissibility from separating what the virus is doing in the body that might be causing long COVID. So short answer is we just don't know yet.
No. Would it be, please completely correct me if I'm wrong, would it be okay to see it this way, that even with new variants of concern, even when the original virus has changed or is changing, in the end, the virus itself kind of stays the same, which means if we know that this virus, once some people get the disease, COVID-19, and then afterwards some people get long COVID, whether or not a specific variant of concern is more transmissible or more deadly, that doesn't necessarily affect the thinking that after COVID, some people get long COVID, that it's not because this is Alpha and not Delta or vice versa. It means you should worry about long COVID, whereas you should not.
Yes, exactly. We need to separate that transmissibility from what the virus is doing that is causing disease. Now, the two might end up being related in some way, but it does look like we need to separate that. Now, the problem is that, when we're talking about these variants, we're often just focused on saying, okay, is there a difference in transmissibility, in disease severity, or in immune evasion? Those are the three things that people are really looking at. And in terms of disease severity, this is hospitalizations and fatalities during the acute infection. So if there's a change in long COVID disease severity, or if there's a change in long COVID incidence, or a change in long COVID symptomology, that's not being looked at as consistently with the different variants. And it's possible that a variant that comes about that has exactly the same transmissibility changes the long COVID disease because there's some change in the virus that affects how it interacts with the immune system. And that changes long COVID disease. We don't know that that's happened. We don't know if that's even possible to occur because we don't really know exactly what's causing long COVID. We don't know why in some people that acute infection goes on to have these persistent symptoms. So it's possible that any variant will come about that will change either the incidence of long COVID or something about the disease itself. But we have no evidence to say that that has occurred yet. And it's entirely possible that will never occur.
So right now, with the information that we have and what we know is that even if it's a variant of concern or the original virus, right now, long COVID comes after COVID for certain people.
Exactly. Unfortunately, we can't be a whole lot more specific than that outside of taking that sort of population level data like has been coming from the UK and saying, yeah, we're looking at about 14% of people that got infected developing long COVID. But yeah, how that's changing with different variants over time, we don't know yet.
Okay, so this was the variants part of the episode. And now we already touched a little bit some points on vaccination, but now let's really talk about vaccination. So just a little recap of where we're at right now. As of yesterday, according to our World in Data, almost 26% of the world population had received at least one dose of the COVID-19 vaccine. This actually means that it's globally, around 3.51 billion doses have been administered, and around 30 million are basically administered each day. That's a huge number,
Yeah.
but we need to like keep in mind that out of this percentage, only 1% of the people in low income countries have received at least one dose. So that actually means that each country has a different reality in this pandemic. And that is why that, you know, some of the long or most of the long COVID questions regarding vaccines are especially important, and especially if we are specific about it, because it's quite different. It's different in the US when compared to Latin America, when compared to Asia, when compared to Europe, and so on. So, Jeremy, does vaccination protect you from long COVID? That's the first question.
That is a question that is so critically important because we're hearing so much about vaccines and do they protect you from severe infection? Do they protect you from fatal infection? And the answer is yes, they do a very good job on that. But what about long COVID? And we're just starting to get some data for that. But unfortunately, that has been really delayed in getting this data. So, the clinical trials that were done to look at, how efficacious is the vaccine? How well does it stop getting infected? How well does it stop COVID fatalities? They were not designed to look at long COVID. And often in these studies, the percentage of people that were vaccinated that then ended up getting infected were fairly low. And so that didn't give a lot of numbers to really then look at how those people fared over time. But we're starting to get a little bit of information right now. So actually, some of the sort of the best data that we have right now comes from a recent survey by Survivor Corps that was looking at of people that were recently vaccinated, how many of those actually got what they're calling a breakthrough infection. And so what we mean when we say breakthrough infection, and this is not like a standardized term, but sort of the common usage here is that somebody that has gone through the full vaccination process. So if you had Pfizer or AstraZeneca, you've gotten the 2 doses, and then you're at least 2 weeks after having that second dose, because you need that time after that second dose to build up your antibody response. So that's what we're talking about, fully vaccinated. Or, if you had Johnson and Johnson, then just the 1 dose. But of those fully vaccinated people, what's the percentage of them that end up getting a COVID infection, testing positive for COVID? And then from those people that had that breakthrough infection, that tested positive despite being fully vaccinated, what percentage of them have developed long COVID symptoms? And so that Survivor Corps study said that 38% of breakthrough infections in fully vaccinated people were leading to long COVID.
30.
So 38%. So what this suggests, and this is preliminary data, this is based on a survey, so we need a lot more data. This is really important, but one of the things that they were saying when they did this survey was saying that we need this data. As we're talking about here, we need this data, and that data wasn't forthcoming. So they needed to go to patients, they needed to go to the community and start getting this data just to be able to answer this question. So this is the start of that data, and hopefully we'll get a lot more. We'll be able to answer that really thoroughly. But it does look like vaccination reduces the likelihood of developing long COVID. But it looks like it doesn't eliminate the likelihood of developing long COVID. So, still 38% of people getting a, breakthrough symptomatic case of COVID disease are seeming to develop long COVID symptoms. So it on one hand, that's not entirely surprising, because as we've talked about, you can have an asymptomatic case of COVID, you can have a mild case of COVID and still go on to develop long COVID symptoms. So, the vaccines they're clearly helping. They're clearly reducing your risk of getting long COVID, but they're not eliminating that risk of getting long COVID.
And just to make sure I understood, so the study was made and they spoke to an X amount of people. And out of this number, it was seen that 38% of the people that had been fully vaccinated that got COVID, despite being fully vaccinated, then went to have long COVID, correct?
Yeah, 38% of people that had been vaccinated that got COVID and developed symptomatic COVID disease, even mild symptomatic COVID disease, but developed symptomatic COVID disease, then went on to develop long COVID. So, yeah.
So it's not necessarily about the symptoms, it's just about getting COVID and then afterwards long COVID.
Yeah.
Okay, so I got it right, but I just want to ask you, because I'm sure if I was a little bit unsure, there might be someone else like me that is also unsure. Why did you then say that it showed a decrease of likelihood of long COVID in this case? Is it because you were thinking about the data that says 60-80% of the people that get COVID get long COVID, or
So yeah, because it's you can just take that 38% number and say, well, wait, that doesn't sound that's not good. But it's 38% of the people that develop symptomatic breakthrough infections. And the likelihood of developing a symptomatic breakthrough infection when you're fully vaccinated is dramatically reduced. So, I mean, we were saying even with Delta variant, you're at between 65 and 79% protected against developing, a symptomatic case of COVID disease. So you have this dramatic reduction of your likelihood of getting a symptomatic disease. And if you do have a symptomatic disease, then your likelihood of developing long COVID is further reduced. So the vaccines do have this additive effect, but the point being that there is still a risk, and there are people that are having breakthrough infections that are developing long COVID. But again, the vaccines are still really good at preventing severe infection, fatal infection, and reducing your likelihood of getting symptomatic disease and developing long COVID. So it's helping on all the different levels, but it's not eliminating the risk. And I think that that's the important point, is that the vaccines are not a one thing and then the risk is gone. They are dramatic risk reduction, and it's a great tool, but it doesn't eliminate the risk.
Okay, so yeah, now it's much clearer, and it's also a reminder that whatever you hear and whatever you read, that you understand what exactly is it taking into consideration, right? Because when you said the number 38%, and then you said it has the likelihood, the risk of getting long COVID has decreased, in my mind, I was like, well, 38 sounds like a lot to me. But then, of course, when you clarify and then yes, I remember. Okay, we're talking about breakthrough ones. So from the people that got vaccinated, fully vaccinated, it's a small amount of number because it protects you. So it's a small amount of number of people that get COVID. And
Right.
so from the people that get COVID after being fully vaccinated, then this is the number for long COVID.
Exactly.
So now,
Exactly.
yes, now I see it that way. Now I say, yes, it's good. It's not perfect, but it's good.
Exactly. And I think that I like that framing, because it's really good. It's not perfect. And I think it's important to realize that it's not a perfect protection, but it's a really good protection.
And I'm gonna go back to it because it's just something that it needs to be clarified. Does it depend on the variant or on the vaccine, or on both?
It Yeah, that is an answer that I would love to be able to give. We don't know. They were talking in the survey that there was a little bit of difference between the vaccines. Maybe that's a difference that stems from the difference in efficacy of the different vaccines in preventing symptomatic cases to begin with. So how they're working in the body is a little bit different. It may be different from variants. This is just the very start of this answer, and hopefully we will be able to answer that question, how the variants are affecting, how the different vaccines are affecting um, the propensity to develop long covid. I don't know right now.
So we can say that for people that ask or wonder, if I get COVID and I'm fully vaccinated, does it also protect me from long COVID? Would it be correct of saying it protects you much more,
It protects you, but not completely.
but not
and
completely?
and that is the same statement for the vaccines in general. It protects you very well, but it's not 100%.
Not
And it's just important when you're thinking about the risks, when you're thinking about viral spread, when you're thinking about precautions. It's important to know that you are protected, but it's just not perfect protection.
exactly. So if you're able to, get your vaccine.
Yes.
Jeremy, as always, it has been a pleasure talking to you. And I think it's been great. Thank you very much to everybody that has sent their questions. And yeah, that's it. The long haul. Jeremy Rossman, Laura Maria Calderone. Thank you.